Attendees are in listen-only mode.
Hello, and welcome to the HDSA Caregivers Corner webinar series. Before I invite the presenter to get started, I'm going to go over how to ask a question as well as how to access this webinar after broadcast. So we're going to be answering all questions after the completion of the presentation. However, you may send your question at any time. To send a question, just go to the control panel that you see on the right-hand side of the screen. Type in the panel and type in your question and hit the send button. This webinar will be available for viewing approximately 1 week after broadcast on the HDSA national website, www.hdsa.org. To access this presentation, go to the website and scroll down the home page, the frequently used shortcuts section on the right-hand side. You will see a link to the Caregivers Corner webinar series as well as the PowerPoint presentation. You may also view all of our webinars, including our Lunch and Learns and Caregivers Corners, in the Living with HD section of the HDSA website. And now I'm pleased to introduce the presenter, Dr. Napolis, who's going to be talking about managing psychiatric symptoms in HD. Dr. Napolis is a Kate Daum Research Professor of Psychiatry, Pediatrics, and Neurology, Vice Chair for Research in the Department of Psychiatry, and the Director of the Iowa Medical Student Research Program. Dr. Napolis' research focuses on the study of brain and behavior. She's interested in aspects of understanding normal, healthy brains, such as differences in brain structure and function between the sexes, as well as understanding how the brain changes. In regard to the study of disease, one of the focuses of her lab is on HD. And Dr. Napolis earned her Bachelor of Science in General Science and her medical degree at the University of Iowa. And she completed her residency in the Department of Psychiatry and then spent 2 years as a postdoctoral fellow in neuropsychiatry in the Department of Psychiatry and also at the University of Iowa Hospitals and Clinics. And now I'm pleased to turn it over to Dr. Napolis.
Thank you so much. I want to make sure everyone can hear me. Am I coming through loud and clear? Good. I think good. The other thing I wanted to emphasize is that although you can ask a question at any time, please feel free to ask any question. So meaning that there's no stupid question. Don't be embarrassed. Anything that I say, it's important to make sure that everyone understands. And I'll try to explain. Sometimes physicians have a way of going through terms which only they understand. So, and sometimes we forget that other people don't know those terms. So please feel free to ask any question. So just as a reminder, I'm a psychiatrist, and although much of my early years was schizophrenia, I've been treating patients with Huntington's disease now for the past decade. So it's actually relatively unusual to have a specialty in Huntington's disease, but it's one of the things that has been a great boon to my career. It's been very enjoyable for me. I do research in Huntington's as well. But a lot of the things that I'm going to say come from not only the field of research, but also, importantly, my experiences in treating patients with Huntington's as a psychiatrist for the past decade. So I'd like to just outline the things that we're talking about today. So obviously, in the three-pronged symptoms of Huntington's, we have motor, cognitive, and psychiatric. Today on the psychiatric symptoms, which are really, and in the context of the psychiatric symptoms, I think it's important to address why it's important to learn. One fact is that they often appear years before the onset of motor symptoms. Motor symptoms are the definition of the clinical onset of the disease, but oftentimes psychiatric symptoms can come on years before, even decades before. And so it's really important to be aware of some of these things even in the very early courses of the disease. They can have a large impact on functioning. So symptoms that we'll discuss of depression, symptoms of what we call frontal lobe syndrome, any kind of behavioral or emotional disturbance can have a big impact on patients' ability to work, have relationships, functional, and so they really can have a large impact. And most importantly, it's really helpful to know that they're treatable. They're actually one of the most treatable aspects of the disease, and so really important for people to understand what the symptoms might occur and how to monitor for them, and most importantly, to get help for them because they can be treated. So this is an outline of some of the symptoms that we're going to be talking about, and I'm going to go through each one of them and in relative specificity talk about each one and about treatment of each one. So let's start out with depression. So depression is, simply put, feelings of sadness, hopelessness, feelings of guilt. They're often accompanied by decreased sleep, appetite, decreased energy, thoughts of death or suicide. It actually is something that happens commonly. There's been lots of studies that will show what percentage of patients will experience depression. I must say they vary a lot, anywhere from 40 to 60%. But I think it's a little bit more important to focus on the timing because the symptoms of depression are often seen early in the disease, sometimes right before treatment or right before diagnosis or right after diagnosis. So in the early phases of the disease, this is something that is one of the more common symptoms that we see. There is a higher rate of suicide in Huntington's, and around the same time period when we know that depression is higher. So it's the early phases of the disease. And it's really important that we focus on these things because they need to be monitored and of course they can be treated. In general, the suicide rate is a little bit lower than seen in the general population who suffer from depression, but it really goes hand in hand. So in other words, the suicide rate is, in Huntington's is directly linked to the rate of depression that we see during this time. Really important to monitor these symptoms. And the reason for that is it's important to think of suicide as something that can be prevented. So in particular, if it's coming from depression, and it can be treated. And it's really difficult sometimes for patients and families to discuss openly depression. In particular, it's difficult to talk about suicide. There's oftentimes this misconception that if families talk about suicide, that it'll somehow plant a seed of wanting to do it in someone's mind, which is absolutely not true. You can't coax somebody into do it just by asking them. But simply asking about their mood and if they're having thoughts of death or suicide is something that's appropriate to discuss. And even if it's difficult for family to discuss that, definitely any physician caring for patients with Huntington's need to screen for depression and thoughts of death and suicide. For me, because I'm a psychiatrist, it comes second nature for me to ask these things, but it's really important for family to become comfortable with it too. The analogy is if your family member was suffering from a fractured leg, you ask them how their pain is that day. And same thing, if you have a family member who's suffering from depression, you ask them how their mood is that day and if they're having thoughts of death. So in general, screening for symptoms of depression and suicide is really important, in particular because these are things that can be treated. One note I'd like to make is that tetrabenazine is a medication that is used to treat involuntary movements in Huntington's. It's something that's FDA approved, and it has been used in the past several years for treatment of chorea. One potential side effect from the tetrabenazine is depression. So it's something that we think about whenever our patients are prescribed this medication. We discuss with them that this may potentially cause some depression, and we monitor even more carefully in those subjects who are treated with tetrabenazine. So now I'm going to speak a little bit about treatment, and I want to step back and give an overview very briefly and very generally about some of the workings of the brain. So when we treat psychiatric symptoms, one of the major things we use is medication. We'll talk about other things as well, but the primary thing is medication. And the medication works in the brain, so it works on the brain cells, which are called neurons. And the neurons work by communicating with each other, passing back and forth specific chemicals. So this picture that you see here is of two neurons. So, and they're communicating. The little red lighted cells, or the little red lighted dots in between these two cells, is the chemical that is passed back and forth. And this is how neurons communicate, and how the brain works is by these neurons talking to each other and then responding to their environment through this passage of chemicals. These chemicals are called neurotransmitters. So remember, neuro means brain. Neuro are the brain cells. So these are the chemicals that pass between. So you'll hear me use that term, neurotransmitters. In general, this is an oversimplification, but all psychiatric medications work by changing the amount of neurotransmitters in certain areas of the brain. So all of the different classes of medications that I talk about, in general, are working through this mechanism. So specific chemicals or neurotransmitters that change the function, and in particular, sometimes in different regions of the brain. The brain is divided into lots of different sections that govern different things. So the area of your brain that involves motor movement is a different area of your brain that involves mood and emotion. And so it's targeting specific areas and specific neurotransmitters. So back to treatment after that broad discussion. In terms of treatment of depression, we often get really good response. So this is one of those things that's important, is depression needs to be monitored because we can affect change with our treatment. So in this discussion on this slide, the red text indicates the name of the neurotransmitter. To be honest, it's not really important to know specifically because, like I said, it's not going to make a difference, so to speak, in terms of the treatment. But in terms of hearing these names, it'll be helpful to understand what it is that we're talking about. So there's lots, I'm sorry, that's a typo. It says lots, but it should be lots. Lots of different kinds of antidepressants. So one of the most common ones is called SSRI, which is selective serotonin reuptake inhibitors. And the serotonin is the neurotransmitter that these drugs work on. These are the ones that you've probably been familiar with. These names are probably familiar: Prozac, Celexa, Paxil, Lexapro, and Zoloft. SNRIs work on serotonin and another chemical called norepinephrine. These are Cymbalta and Effexor. And then norepinephrine dopamine reuptake inhibitors, a couple different chemicals, and that's Wellbutrin. I think what's really important is that there's no specific medication that has been shown to be more effective for Huntington's. So this makes it easy, meaning that you treat the patient according to what medication works best for them. There's not one of these that has been shown to be more helpful in Huntington's, so we use all of them. Oftentimes, the SSRIs are typically considered to be what we call first line, and oftentimes it's one of those medications that a patient is started on. These medications are typically very well tolerated, so there's not a lot of side effects, but of course that's what drives the changes that a physician might make. If one patient has side effects from one medication, you switch to another. But all of them have been shown to be effective in depression, and all of them can be helpful in the depression that we see with Huntington's. The next term is apathy. Apathy is lack of interest, lack of drive, lack of motivation. It can be a part of depression. So oftentimes, depression can come along with apathetic symptoms. But more importantly, for Huntington's disease, it can often be mistaken for depression. And this is in particular later in the course of Huntington's. It may be related to problems in poor thinking skills or cognitive skills, which decline with the course of the disease, sometimes often to the point of what we call dementia. And apathy in the context of having all these symptoms but not being sad can happen. So for instance, if families are concerned that their loved one with Huntington's is no longer leaving the home very much, not doing the activities that they used to do, and not even really having interest in the activities that they used to do, it can sometimes look from the outside like depression. But what's really important is to ask the patient, ask the loved one with Huntington's what they're feeling. And oftentimes, if it's just apathy, they will say that they're not sad, just that they don't have interest. And oftentimes, when cognitive skills get impaired, it's more comfortable for patients to be a little more isolated, so to speak, meaning that oftentimes when there is significant cognitive impairment, sometimes going out of the home is very stressful and anxiety-producing. So sometimes later on, when patients become more secluded and apathetic, it's really important to try to distinguish, is it just apathy, or is this really a depressive syndrome that's coming on? And once again, it really pivots on this notion of whether or not the patient with Huntington's is feeling sad. If they're feeling sad along with the apathy, then it's appropriate to. But if they're apathetic but not feeling sad, then it's not necessarily time to treat with an antidepressant. I can say in general that when there's apathy and not depression, it doesn't respond as well to treatment. So apathy is a little bit harder to treat when it's there by itself, not with depression. Sometimes we use Wellbutrin. Now, yes, Wellbutrin is an antidepressant, but it's one of the antidepressants that is what we call activating, meaning that it can provide a little energy boost, and sometimes this is used to try to target apathy. In general, it's the whole syndrome of apathy is a little bit less amenable to treatment, and depression is usually responding better. The next category that we'll talk about is frontal lobe symptoms. So what I mean about this is it refers to the part of the brain that governs these kind of behaviors. It's the front part of the brain. It's the part behind your eyeballs. And this part of the brain is important because it governs what we call higher order behavior, higher order cognitive thinking. And it's things like irritability, anger, disinhibition, planning and organizing. These types of functions are governed by the front part of the brain. And importantly, this is an area that can be primarily affected in Huntington's. it really is these next group of symptoms, and in particular, I'll get to in a minute, but in particular the irritability, is really the most common things that I see in Huntington's. It's really the most common behavioral problem and the most common treatment that I provide in the clinic. Oftentimes these symptoms arise as a personality change. And the first one I'm going to discuss is agitation and irritability. So this is really seen throughout all stages of disease. I often see it early in the course. Early in the course of the disease, the patient with Huntington's has a lot of awareness that they have this problem. And they'll say, you know, I'm really irritable, it's just not like me. There may be quick shifts in anger and even rage, meaning that the mood shifts very quickly and kind of spontaneously, somewhat unpredictably. So getting irritable with an explosive anger for a tiny thing which shouldn't really cause that much anger, but it goes off. Later in the course of the disease, this can be a major problem, in particular in the context of placement into a care facility. Because in a care facility, the care providers are very vigilant about any kind of potential aggression. This is for safety reasons, safety for the staff, more importantly, safety for some of the other patients in the care facility. And so, in general, the notion that a patient may be aggressive is something that will make it difficult in terms of caring for them or finding a care facility to take somebody. So these kind of symptoms are important to try to monitor and manage as well as possible. So agitation and irritability, in my opinion, is responsive to medication treatment. And I think this is the really good news about this area. And in particular, I've had really, really good success early in the course of the illness. So I'm going to talk about antipsychotic medication. It's important to distinguish what this means. We'll actually talk about psychosis later on, but this is a class of medication that works specifically on a chemical called dopamine. This class of medication works specifically to decrease the irritability and the mood shifts that we see. The common one is Risperdal, and this medication is used in my hands very, very commonly. So this is one of the newer forms of what we call the antipsychotic medications. There's a whole class of them that are very similar. I find this one to be the most useful in my hands. In particular, what's nice is that the HD patients, especially early in the course, respond very well to small doses of these medications. They're powerful medications, and so it's really important to start very slow and to start low. But oftentimes, it's seen that the irritability and the mood shifts can respond quite well to very low doses. You can also try antidepressant medications to help with these mood shifts. In general, once again, in this context, we're not necessarily targeting depression, but we're targeting the agitation and the irritability that can. You can also try mood stabilizers. These are used to treat bipolar affective disorder or manic depression. So they're medications like lithium and Depakote. So once again, similar to what I said about antidepressants, there's lots of different kind of medications. None of these have necessarily been shown to be more effective than the others. And for some patients, one might work well, and the other patient might respond to a different medication. In general, in my experience, the Risperdal at low dose is one of the most effective treatments that I've had experience with. The other symptoms of the frontal lobe symptoms are things like impulsivity and disinhibition. This may lead to poor decision making, which may have negative consequences. So making an impulsive decision without really thinking through it very carefully, or without thinking through what the consequences, or being disinhibited. These are behaviors that once again can change potentially slowly over time, and for family members is difficult because they're typically not acting like the person they used to act like. Lack of insight or lack of awareness is important. So being unaware that you're having changes in your thinking, that you're having changes in your behavior, that you're having changes in the way that you treat other people. This is something that's actually quite common and in general gets more severe over time. And it makes it difficult sometimes for families to communicate because sometimes the loved one with Huntington's isn't aware of the changes that are going on in their behavior and in their mood. And it can cause some friction with family. But it's important to be aware of this possibility and be as open as possible about talking in terms of what the family member is seeing and how they're viewing things. There's always two sides to every story. And in particular for the physician, for the psychiatrist, it's really important to get not only the patient's perspective, of course very, very important, but talking to family members can be extremely important in trying to understand what's going on with this patient. Because oftentimes the subject with Huntington's may not have a good awareness of what others see. It's not uncommon for us all in our own behavior. Sometimes our family sees us in a different way than we see ourselves. But it's one of the reasons why it becomes, for me, imperative to include family members in all aspects of treatment of Huntington's, and in particular with the psychiatric symptoms. So I'll just underline how important that is to be involved in the care with the physician and working together as a team, patient, loved one, caregiver. In general, these two symptoms, a little bit in contrast to the irritability, are not as responsive to the medications as much as the mood shifts, but they can, and in particular the impulsivity, in the same way that irritability can be modified by the medication. It can help at some level. In terms of anxiety, anxiety is something that is not as common. I can tell you that I definitely have seen it. I have some patients in particular where it's the most problematic symptom, but it's not as common as some of the others. It usually occurs as generalized, and what I mean by that is that it's a feeling of nervous or anxiety that is present most of the day. And this is in contrast to things like a panic attack. So a panic attack is something in which you're totally calm without problems, and then boom, something, you feel panic, and your palms are sweaty, your heart races, you feel very nervous, and it's very intense. And in general, that's just different than the generalized anxiety in which there's a level of nervousness that's there most of the day. The treatment for anxiety can be SSRIs, the antidepressants. But another class of medications that it's important to be aware of is the benzodiazepines. And these are Valium-like medications. So this class of medication work in a similar way. So these are names that might be familiar: Xanax, Ativan, Klonopin. Valium, of course, is in that same class. But these are medications that are specifically what's called anti-anxiety medications. And along with antidepressants, can be really effective for treating anxiety. Obsessions and compulsions. An obsession is an intrusive thought that comes over and over. I call it a mental itch. So an example of an obsession might be, I'm contaminated. I touched something with germs. So that's a thought that comes. And the person who has an obsession doesn't like it. It's an unusual thought. They're aware of the fact that that is kind of a weird thought. They don't like it. But it comes over and over and over again, and they can't stop it from coming. A compulsion is a behavior that often follows an obsession to relieve it. So if you have a mental itch that says, I'm contaminated, I touched something with germs, the scratch might be washing your hands over and over again. So a compulsion is behavior that is often done to help relieve the obsession. Cycle of behavior that happens in response to an obsession. So this kind of what I would consider, very basic and common obsession and compulsion is not something that commonly is seen in Huntington's, but something very related that is common in Huntington's is perseverative thinking. So this is often later in the course when cognitive skills are diminished. And it's focusing on an idea and a thought over and over again. So patients will often be very repetitive, and they'll stick on one idea and talk about it over and over again. It may be due to poor memory. So for instance, oh, I have a doctor's appointment today. What time is that? The answer, the appointment's at 10 o'clock. 5 minutes later, I have a doctor's appointment today. What time is that? So potentially it could be due to having a poor memory, but oftentimes it's also just what I call sticky thinking. It's similar to the obsessions that I talked about before, slightly different. It's not necessarily an intrusive thought that the patient thinks, oh, that's a weird thought, but instead they're just stuck on an idea, and it's not necessarily problematic for them. It can be problematic for the family members. They really can't get unstuck from those thoughts. Psychosis is something that's defined as being delusions and hallucinations. The definition of a delusion is a fixed false belief. An example of that is I'm being poisoned by my family. That would be what we call a non-bizarre delusion. And the reason we call it non-bizarre is because it's in the realm of possibility, meaning that it's possible. It's unlikely that it's happening, but it's possible. A bizarre delusion might be something like aliens are invading my brain, something that's quite unlikely to happen. A hallucination is, for example, it can happen in any sensory modality, so it can happen with vision, smelling, touching. It's most common to have auditory hallucinations, which are hearing a voice when no one is around. These symptoms can occur anytime throughout the course of the illness. I've had occasional patients who, long before their diagnosis of Huntington's, received a diagnosis of schizophrenia. That's not common. It has happened. And in general, it's really something that occurs only in about a quarter of the patients. It's also a little more common in patients with earlier onset, those with symptoms in the teens or early 20s. The treatment is with antipsychotic medications. So those are the medications that I talked before about treating irritability and anger. They're often very specifically used for hallucinations and delusions as well. It's really important when I tell my patients when I'm using antipsychotics to treat for irritability, it's important for them to understand I don't think that they have hallucinations and delusions, but these medications are used for several different things. Just like aspirin. Aspirin can be used for a headache. It can be used in the context of a heart attack. So many of our medicines in medicine and in particular in psychiatry can have a broad range of effects, so we can use them for different things. So in the context of that, there's multiple effects of these medications. I mentioned the antipsychotics like Risperdal block dopamine. And dopamine is a chemical, it's a neurotransmitter that's involved in motor movements. So for instance, Parkinson's disease is not having enough dopamine, but chorea is having too much dopamine. So blocking dopamine actually reduces chorea. It may also help in some of the other motor symptoms of Huntington's by helping balance and coordination. I'm going to back up. So just to emphasize for that, what I call medications like the antipsychotics, I call them twofers, meaning that they can often have more than one effect. So oftentimes, if I have a patient who has both irritability and some chorea, if I use a medication like Risperdal, they will have potentially two separate effects, a decrease in the irritability and the mood shifts, but also a decrease in the chorea and an improvement in the motor symptoms. So similar effects with the Valium-like medications. These are actually medications that also decrease movements. So oftentimes, if I'm treating a patient with anxiety, and I'm using a benzodiazepine, that treatment for anxiety can also help quell or decrease the abnormal movements as well. Both of these medications, the antipsychotics and the benzodiazepines, help aid in sleep as well. So it's really important to focus, I know, as physicians, and in particular sometimes with psychiatry, people may be averse to the notion that this is just pill pushing, so to speak. In general, all of medicine is treatment with medications, but it's important to realize the other aspects of treatment that are really important to consider and to employ in the holistic aspect of taking care of patients. So it's very important to think beyond just the medication. Education, education, education is so important. And for those people who understand potentially what symptoms might be occurring in Huntington's, are then able to monitor for those symptoms, and when they're there, getting appropriate treatment. It's also understanding, too. Oftentimes, psychiatric symptoms or emotional symptoms, patients are less likely to talk about it. They may be more ashamed of it. They may feel like this is their fault. So for a patient who's suffering from Huntington's disease, this is insult to injury. The stigma of Huntington's can be then worsened by the stigma of mental or psychiatric symptomatology. So it's really important to empower patients to understand that this is completely appropriate to think about, understand, and treat. This is not their fault. It's no more their fault than their chorea. But more importantly, making sure that family and friends and everybody understands that these are that are a part of the disease and should be watched for and can be treated. Family support in that context is in the same vein, meaning that the family who understands about the psychiatric and behavioral aspects can be a partner with the patient to make sure that those symptoms are monitored and treated. Counseling is always an important part of healing. And in many ways, counseling can be effective, both for individual counseling for the person suffering from Huntington's, or couples counseling for those who are dealing together with the disease, and even family counseling. All of these mechanisms are simply ways in which people can increase communication, can understand better the level of support and coping mechanisms for dealing with anything that comes, not just the psychiatric symptoms, but really dealing in general with the disease. So counseling, I think, is really important as an adjunct to all the treatments that I've discussed. So who to get treatment from for psychiatric symptoms? So I'm biased, I'm a psychiatrist, and so I'd like to think a psychiatrist is really good, but important that sometimes it's not available, and it's not always necessary. And the reason for that is because although few psychiatrists are going to know an awful lot about HD because it's so rare, it's more important that they understand the medications and how to dose the medications and what the medications are used for. And so even though the psychiatrist may not have a lot of experience in Huntington's, they know how to treat symptoms that I've talked about. So they will know how to use these medications to treat those symptoms. And most importantly, because the treatment isn't necessarily different than a patient without Huntington's. So in general, the treatment of depressive symptoms in a patient with Huntington's is in general no different than the treatment of a patient without Huntington's with depression. And so in general, the psychiatrist or an expert in someone who knows these medications is an appropriate person to manage this kind of treatment. In that vein, many neurologists are excellent at treating psychiatric symptoms, and many neurologists in particular who are Huntington's are also expertise in some of these medications. And because psychiatric symptoms are so common, family practice physicians are also well-versed in these psychiatric medications too. So in general, any medical care provider is capable of providing the treatment for the patient with Huntington's. It's helpful for them to understand Huntington's, and in general, an expert in Huntington's, I think, can give some extra added advice. But this care team, I think, is all appropriate. The other thing is consultation. So knowing the specifics about Huntington's disease can be helpful. And there's a really important guideline that's free download. It's the HDSA Physician's Guide. And this guide is something that you can download, really important. You can download and read yourself. I think it's really helpful and important. But it's also totally appropriate to give this to your physician. Many physicians, because Huntington's is rare, will be welcoming to other information to aid them. But working with your physician and educating them about what you and your family are dealing with, I think is a great way to open up communication and make sure that everyone is on the same page. So I think at this point that's all of the slides I have, and I'm happy now to answer some questions and open for discussion. Okay, I have one question here. It's a good question. So can Risperdal, which is the antipsychotic medication that I talked about, be taken with tetrabenazine? That's a great question. In general, yes. It is important to consider combined side effects with those medications. They both work on dopamine. They work actually in different ways. Tetrabenazine is a medication that decreases dopamine, and Risperdal is a medication that blocks the effectiveness of dopamine. The only potential concern is that both of these medications can very rarely cause a problem with heart rhythm. Now, once again, it's very rare, but because it's a somewhat severe problem, if you're on both of those medications, it's possible that your physician will ask you to get an EKG which is a heart tracing, and it'll just look at the rhythm of your heart. It's very likely that there'll be no problems whatsoever, but sometimes when those medications are combined, then you just need to be careful about the side effects that can happen with the both of them together. Here's another great question. Is there a directory of psychiatrists in the U.S. who have HD experience? That would be a short directory, I'm sorry to say. It's actually a great question, and maybe it's something that I can work with Jane and the HDSA to think about that. My personal opinion is that I'm dedicated to the treatment of these patients, and I'm always happy to talk to family members and patients, and in particular physicians who are looking for help in treating their patients. And I know some of the other psychiatrists who are involved with Huntington's are the same way. There are relatively few of us. There's only a handful of us in the country who have a relatively extended experience. In general, we're physicians who work in a tertiary care center. So we work in these large hospitals where we have centers of excellence, meaning that patients with Huntington's come to see us. When you're out in the community, even if you're working in a metropolitan area and you're working in private practice, you're in general not going to see an awful lot of patients with Huntington's. So it's really these university-based clinics in which physicians like myself will get specific experience in rare disease. But that's a great question. It's something that I'd like to work on to see if we can make it an availability. Here's another question. How do you know when things have gone too far for the HD patient to be cared for at home? Great question. In general, what happens is that families need to discuss this at length with each other, and oftentimes it's clear that sometimes the care that the patient with HD needs is just above and beyond what the family can provide. This is really difficult because often families feel like they can do it all. And unfortunately, sometimes families can't. Most of the time, families can't provide it all. And so families often will go to the very end, meaning they'll go to the point where they're stretched so thin that they, endanger their own health in terms of trying to care for the patient. So oftentimes it's really something that the caregiver needs to understand and needs to understand their limitations. And when they're ready to say, this is above and beyond what I can do, then that's the time. Sometimes it's really important for caregivers to get support for their own mental health, and others can help in making the caregiver make the decision, this is the time for it to happen. Another question here, my sister has HD and is exhibiting many of these signs and symptoms, including poor judgment, rage, irritability. She is still driving, and her husband is fearful of her rage, is not dealing with this. How can I intervene to have her license evaluated? Yeah, the difficulties that come with these experiences, and in particular with subjects who don't want help, makes it really difficult for the family to deal with. The best advice that I can give is to try to keep as much communication as you can. I know sometimes intervening may mean that the family member becomes upset and cuts off communication, and that's a risk for intervening. But on the other hand, gentle nudging and communication, not only with your sister but with her husband, to try to have a united front to help convince her that she needs some help and direction. The driving is an issue that we deal with all the time in the clinic. And interestingly enough, even though chorea, you can imagine, might interfere with driving, the biggest factor that determines safety behind the wheel is not chorea or motor problems, but it's the thinking skills. And it's not necessarily the psychiatric symptoms, it's the thinking skills. So people who have problems with attention and concentration are at higher risk behind the wheel. I think in general, for someone who may be having troubles with driving, getting an over-the-road test by the Department of Transportation before they get their license renewed is something that can really be a safeguard as to whether or not this person can actually drive a car. Another question here, treatment for perseverative thinking. In general, so this is something that's a little bit more difficult to treat in general because it's a little bit farther in the course of the illness. Potentially something in the antipsychotic range, so the potentially low-dose Risperdal may help that. In general, I wouldn't expect that it would change it dramatically, but it's also reasonable to consider that small doses. The other thing is that for what I would call similar kinds of thinking, the obsessions and compulsions, high-dose SSRI medications have been used. So potentially for perseverative thinking, something like Prozac may potentially be used for that. How common is paranoia is another question. This is something in general that's on the same spectrum of delusions. So someone who thinks that their family is poisoning them or just thinks that someone might be spying on them or talking about them, that certainly can happen in the context of Huntington's. In general, it's not as common. I would quote it as about maybe a quarter of the patients experience something like this. But once again, sometimes the paranoia is mild, but it also might be something that goes to what I would call delusional proportions, where they become convinced that this is the issue. At that point, something like medication treatment can help with those kind of thoughts. Next question. Would treating an HD patient's insomnia with something like something like Ambien aggravate other psychiatric symptoms? Great question. Ambien is a very effective sleep aid, but it does potentially have some side effects where patients under the effects of Ambien have behavioral changes. So getting up in the middle of the night, not realizing what they're doing, being confused in the middle of the night. So I think in general with Ambien as a sleep aid, it has potential for causing more of those problems. It's a little bit individual. I've had patients who tolerate it just fine, but others it may aggravate some of the psychiatric symptoms. So it would be a medication. I would at least be cognizant of thinking about those things. What can a caregiver do if her spouse refuses medication because he is unaware, even though the doctor has prescribed them? Really difficult situation, not an uncommon situation that we have as a psychiatrist, something that I deal with all the time. And it's very delicate. In general, it's a constant, I wouldn't say battle, but work in progress to communicate with your spouse and the physician that the medications are for his benefit and important. If things got severe enough where the behavior and the symptoms are really at risk, then commitment and forced treatment is a possibility. It's really something that's done only as a last resort, so to speak, and it really is only in the context of if the symptoms are severe enough to potentially do something like be at risk for the patient to harm himself or others. Then you can intervene with the law is what it is. It's a legal commitment for treatment. Prior to that, it's really a work in progress in working with the physician and working with the loved one to try to convince them that this is for their best interest. Looking for the next question. My husband is taking Xenazine for chorea, but has trouble sleeping. He also takes citalopram for depression. Both are very mild. Xenazine puts him to sleep during the day, but he can't sleep at night. Would Risperdal be better? That's a good question. In general, Xenazine has proven to be really effective in the treatment for chorea. And even though Risperdal is pretty good at that, in general, I would have to say that it's probably a better medication for chorea. It does, unfortunately, have some side effects of being sedating, but the problem I think that you're describing is that the sedation is during the day and instead of being at night. It may be possible to change the dose of Xenazine to make it later at night so that it can actually, if the Xenazine is given late enough at night, then it could actually be a sleep aid. I'm not convinced necessarily that Risperdal would be better, but in general, if the Xenazine proves to be too sleep sedating and if it's a problem, then that's the time to try another medication. How does Haldol affect cognitive behavior? Great question. I'm glad someone brought up Haldol. Haldol is an older antipsychotic medication. It's very, very similar to Risperdal, extremely similar. I'm an old enough psychiatrist to tell you that Haldol is a great medication. I used to use it a lot. Gotten kind of a bad rap. And in general, I still find it to be, importantly, very inexpensive and very effective. Once again, it's extremely similar to Risperdal. Now, any of the antipsychotic medications, the question specifically is how do those medications affect cognitive thinking? Any of them in high doses can slow thinking and make you feel like you're thinking through molasses. So potentially that's a side effect, but almost always in the context of medications that are at higher dose. And so medications in lower dose used to treat things like either chorea or irritability and agitation should not significantly affect the thinking. And in general, medications are always, in general, managed by a physician to try to weigh the risks and the benefits. So similar to the statement we made before about Xenazine versus Risperdal, if one of them is giving you so many side effects that it's weighing the benefit, then you think about trying another medication. In general, if the Haldol is a medication that you really don't feel is working well for you, it's time to try another one. Lexapro and Risperdal, are they the same? They're actually not the same. They're quite different. So Lexapro is an SSRI, so it's an antidepressant medication. It's a sister drug to Celexa, meaning that they're very, very similar in chemical structure. So Lexapro is an antidepressant medication that works specifically on serotonin. And Risperdal is an antipsychotic medication that works specifically on dopamine. Would love to block some of the chorea. In general, the Risperdal is going to be much more effective in blocking chorea than Lexapro. Lexapro is the antidepressant, and that won't block dopamine, so it won't decrease the movements. Another question, my husband is in the later stages of HD and he is taking Seroquel. Which type of medication is this? This is an antipsychotic medication, so it's like Risperdal. I use it a lot too. It's a very effective antipsychotic medication. It's more sedating than Risperdal. So oftentimes that's somewhat helpful, is to have some sedating. Can Risperdal be taken with this medication? So adding Risperdal and Seroquel together, they're both in the same class. And even though sometimes, and I can tell you, I have enough experience that I have prescribed both of them in one patient. But for the most part, because they're in the same class, it probably would be best to try to keep one or the other. Can tetrabenazine replace Haldol with less side effects? That's a great question. Haldol and tetrabenazine are very similar drugs, just like Risperdal and tetrabenazine. They're all medications that work very specifically on dopamine and so can decrease movements. They both have side effects. Tetrabenazine and Haldol both have side effects. Tetrabenazine in general, I think, has been better studied for specifically treating chorea. And so in general, I think tetrabenazine would be the first choice, so to speak, over Haldol for treating chorea. But once again, it's very sedating. And it's not, Haldol in general is less sedating. So it may be that if the xenazine is too sedating, that there's a choice for other medications like Haldol or Risperdal. Okay, back to the questions. Many drugs, Zyprexa for one, have severe side effects that then cause other issues like weight gain, diabetes, heart issues. Are there any truly holistic approaches beyond medication? So, excuse me, in general, you bet, any of these medications, any medication, even aspirin, can have severe side effects. Aspirin can cause a bleed in your head. But when you're having a heart attack, you need an aspirin. And in general, we're talking about symptoms on a spectrum that if they're severe enough, then it's time for medication management. Absolutely holistic treatment is always considered. Anything that potentially can improve the health and the well-being of patients is something, in my book, that should be tried, as long as it's not dangerous. And holistic approaches are not. On the other hand, it's a severity spectrum, meaning that holistic approaches are likely to affect and improve moderate to mild symptoms. But once you cross a threshold of symptoms being moderate to severe, then you need to intervene with medical management, and that would be medication. How to proceed if the patient with Huntington's disease is not agreeable to seek medical support and irrational thoughts cause him or her to behave angry and aggressive towards others? Once again, a great question and a difficult question, because oftentimes in the context of having the person with Huntington's being unaware of their symptoms and unaware that they're causing problems makes it really difficult for families. And once again, it's really hard to force treatment. It can be done in severe situations, but oftentimes it's really just the context of the family wanting that person to get help and to get treatment. And the best thing I can say is, first of all, it's not an easy situation, and my heart goes out to any family who deals with this. And in general, just continued support and gentle education that these symptoms might be part of Huntington's, and importantly that these symptoms are causing distress in the family, and that these symptoms may be treated by a physician. And then in general, once care is provided, trying to establish a relationship with someone who really cares for that patient and can also be the voice outside of the family to communicate with them, that's really important too. Next question, do you prefer Risperdal over haloperidol, and if so, why? My wife was prescribed Haldol Risperdal by hospice. Oh, they're both excellent medications. Haldol is an older medication, I'm not convinced necessarily that one of them is much better than the other, and it really depends on the tolerance of the patient. In general, I'd have to say that Haldol may have more side effects, but that's really just a guess, and in general, they're very similar medications. And once again, Haldol tends to get a bad rap. People hear it and they think it's a horrible medication. It's not. In high doses, like any other medication, it can be problematic. Very similar to all the other medications that I've been talking about, like olanzapine or Risperdal. When an HD person has an episode like inhibition, what is the best approach? Should you remind the patient that this is a system, or should you just ignore it? I think the question meant, is this a symptom, or should you just ignore it? That's a great question because it's a little bit difficult. Sometimes it's hard to know exactly what to say. I think in general it's helpful to educate families that some of the things that they're feeling and experiencing are definitely due to the Huntington's disease. That can be hard to hear, especially if they're having psychiatric symptoms but they have not yet been diagnosed with Huntington's disease, because it brings up this notion that they're not yet symptomatic. So I think sometimes it's helpful to educate them that this could be a part of the disease, and that may be why it's important to get medical evaluation and someone who understands Huntington's. And just because, you know, it may be that they're having psychiatric symptoms and they're not yet diagnosed with Huntington's, that doesn't mean it can't be treated. Of course it can be treated. Anytime psychiatric symptoms can be treated. So I think it's important to educate that it might be part of it. But also, too, once again, I think, you know, understanding that that can bring on some anxiety in the patient. Because it doesn't necessarily mean, just because you're having psychiatric symptoms, doesn't mean that you're progressing in Huntington's. I think that's an important piece. Because psychiatric symptoms, unlike the thinking skills and the motor skills, they can come and go throughout the disease course, and they don't necessarily indicate, oh, you know, they're progressing really fast. And so just because the patient is having some problems with emotional problems doesn't mean that Huntington's diagnosis is right around the corner or that the symptoms are going to progress. It just means that they need help with those symptoms at that time. Is there any connection between HD and environmental conditions? You know, I'm not positive about that. And I think it might refer to, are there things in the environment that can maybe make Huntington's worse or bring it on? I'm going to check one more thing on my computer here. I keep on hearing a lot of dings, and I'm not sure why. I am muted. But back to that question about the environment in Huntington's, I think it's an important area I don't know an awful lot. I can tell you in general that there's a lot of things in lifestyle, if you consider lifestyle environment, like you know, healthy living. So alcohol and tobacco and other drugs are probably, in the context of someone who has Huntington's disease, more toxic than someone who doesn't have HD. So for instance, people who are at risk for Huntington's or are currently manifesting Huntington's, use or overuse of alcohol may worsen the progression of the disease. So that's an environmental aspect, so to speak, is lifestyle. Same thing with things like exercise and keeping fit. In general, physical fitness, a lifestyle, or an environmentally induced state is always beneficial, no matter what you have, whether it's Huntington's or anything else. How can you tell the difference in an 18-year-old's typical teen emotions versus HD emotional symptoms? His father had HD. The 18-year-old thinks he may have it too. Fantastic question. Something that I'm quite involved in the context of thinking about children with Huntington's. Others have lots of problems with emotions. Oh, goodness. It's part and parcel of what their brain is going through. And I think in particular when it comes to psychiatric symptoms, much like I said before, psychiatric symptoms don't necessarily mean that the disease is starting or even that they have the disease. So I'm not sure what the 18-year-old is thinking he's basing his feelings on. Is he thinking that he has HD because he's having these emotional symptoms? And the problem is, in general, like I said, we wouldn't necessarily, be concerned or make the diagnosis of Huntington's based on those emotional things. There's lots of things that happen in a teenager's life, and there's even more things that happen in a teenager's life whose parent is undergoing Huntington's disease. So there's so many things that are placed on his plate that can cause emotional and thinking problems. So I think even though it's really hard not to worry about those things, I think in general, only if there were really significant motor problems would I be concerned about the onset of Huntington's in a young person. And the emotional problems can be caused by so many different things that it's hard and difficult and probably inappropriate to say, oh yes, this is from Huntington's. If there are young children in the home, how to help them deal with the mood changes the parent with HD might express. I think in that context, and I'm a big fan of open communication for children. Children pick up so much, and they know so much, even without people or parents talking to them directly. They can pick up so much from a family. I think for children it's appropriate to discuss the behavioral problems as being a symptom of Huntington's. If you see your parent having abnormal movements, you say that's because of the Huntington's, honey. If there's an irritability and rage episodes, that's because of the Huntington's, honey. So it's totally appropriate to consider mood and behavior in the same vein that you would consider thinking skills or chorea as part of the disease. It really helps legitimize it instead of this, and it's totally appropriate. We're not talking about, we are talking about all of these things coming from changes in the brain, whether it's abnormal chorea, abnormal movement, whether it's balance problems, whether it's problems swallowing, whether it's problems regulating emotion or concentrating. Those are all problems that come from brain out, strictly due to the disease. So I think it's reasonable to exactly as that. Next question. A lot of these frontal lobe symptoms be observed long before any chorea is seen. My daughter has been diagnosed, but my son doesn't show any chorea signs, but really shows a lot of the other symptoms. So, twofold answer. Yes, the frontal lobe symptoms can be seen long before the chorea. On the other hand, similar to what I had said before, sometimes it's really hard to hang your hat on the fact that that's Huntington's. It may very well be, but there are other reasons why you can have changes in behavior and things. And so it's really hard, especially early on, to say, oh, that must be Huntington's coming on. Unfortunately, what's frequently happened is the diagnosis of Huntington is made later, and then retrospectively, oh, all of those symptoms probably were related to Huntington's. So they certainly can come on, but once again, I think it's really difficult and probably inappropriate to be convinced that changes in behavior and mood are beginning signs of Huntington's. Really hard to know that. How do you keep from losing your HD patient? Mine does things that he thinks are just normal, and then when it's time to meet, he is nowhere to be found. When you finally find him, he does not understand why you were worried. He gets it that I'm worried and usually apologizes, but always says, I knew where I was. Is there a way to keep a better track or help him understand what we need to know where he is? We have tried cell phone. He never takes it with him. A tracking device, he won't wear it. And I assume from this patient as well that they don't have any family members that you can count on. Once again, I mentioned this before, but for me, it's so important for every patient I take care of, whether they're Huntington's or not, that I have a family member that I work with, and we work together as a team. And so if there's anybody in this person's life who you can call and help remind the patient, hey, you have an appointment, or hey, what do you think is going on, or I haven't seen him, where is he? Anybody in this person's life, or whatever, then I would encourage that. Otherwise, first of all, it sounds fantastic that you're caring and wanting to provide care. So, you know, this person is a lucky man or woman. And just continued education that you need to see him on a regular basis. And other than that, it sounds like a difficult situation that you're doing your best to help with. How to prevent psychiatric symptoms for the caregivers. Really important. I'd mentioned earlier in the context of
Dr. Napoulos, I just want to make a quick announcement to everybody that Dr. Napoulos is answering all of the questions, and I know that many of you have questions, and thank you for going over. If your question isn't answered, we are recording this webinar, and we will, so that you can watch it after broadcast if you have to go. And thank you again for staying on with us and answering all the questions.
Okay, so in the caregiver, I think the most important thing to prevent burnout is to have support for the caregiver. What happens is that the caregiver is the primary support with a patient with Huntington's, but then that caregiver needs support as well, whether it's other family members or somebody else who isn't even involved. It's really important for the caregiver to have an outlet to speak, to let off steam. Counseling, I think, is fantastic for somebody who's a caregiver. The problem I know for caregivers is that they give so much of themselves that they get sick. And it's really hard to carve out the time to take care of yourself when you're taking care of somebody else. So that's the, but it's really important, on the other hand, for caregivers to realize, man, if they get sick, no one's going to be able to take care of their loved one, because that's what they're supposed to be doing. So it's really important for caregivers to try to make sure that they have support in the form of other family members or counseling. And those persons are also really important in helping the caregiver make important decisions about, is it time to move to another level of care, and really just making sure that that caregiver is supported and potentially getting the mental health treatment that they may also need. Prevention is best, and so making sure that there's emotional support, I think, helps to prevent burnout and psychiatric problems. I have 4 children whose father has recently been diagnosed with HD. They are all over the age of 28. None have yet been tested, yet at least 2 of them are showing some of these signs. How do I know if it is HD related or something else? So this is kind of a similar theme to the things that we've discussed before. I must say, as a psychiatrist, like I said, I'm pretty convinced that these are symptoms that of course come from the disease. But on the other hand, these are often symptoms that can come from other things as well. And it's really important not to overinterpret psychiatric symptoms as being part of Huntington's, because they can come from other reasons. And so I think it's for a mother, it's your job as a mother, it's my job as a mother, to worry about our kids. It's what we do. It's what mothers do. It's what our brain is wired for. And so the notion of concern about Huntington's is part and parcel to the whole issue of having children at risk. And of course, being wary of signs and symptoms is important because it is something that you need to monitor and watch for. On the other hand, as I'd mentioned, I think it's really hard to and important not to overinterpret behavioral symptoms. If there are motor symptoms or true changes in functioning, then those are things that would raise a bigger red flag. I think no matter what, regardless of what the cause of behavioral or emotional symptoms is, getting those symptoms evaluated and potentially treated by a mental health professional is important. The other thing is doing the best you can to educate the kids about, their own risk. Obviously, their decision on whether or not they would want to find out anything more about their risk status. Can a person who acts like they have OCD be mistakenly thought to have HD? Well, it can happen that OCD can be a presentation of Huntington's. It's just not that common. I have not seen any patients who really have what I would consider true blue OCD. There's often the perseverative thinking, like I'd mentioned before, which occurs later in the disease course. But I would say it's relatively uncommon to have the diagnosis of OCD. Having said that, you never say never, and it is a symptom that potentially can happen with HD. My husband has Huntington's, but no health insurance. Any suggestions on natural items that can help until he gets a Social Security disability that we've applied for? That's a great question. I think in general, one of the things that I'd mentioned before that were essentially lifestyle issues were, trying to make sure that there is no alcohol or substance use that can potentially worsen or potentially hasten the development of the disease. Again, physical fitness is just, I can't underscore the importance of that in both mental and physical health. And especially in the context of Huntington's, physical fitness has been shown to be really important. Those are natural things to help. There isn't necessarily anything in particular or specific for the psychiatric symptoms other than those things, general overall health issues. What is the best course to manage HD when you are still asymptomatic? Well, I think that segues perfectly into the last question, is that in the context of someone who's at risk, may have the gene but doesn't yet have symptoms, it's all about prevention. So prevention, and we know all those things mean clean living. So no alcohol, and I'm not saying none, I'm saying minimal use. Minimal use. I think it's a little too strict to say none. Minimal use of alcohol or substances, and then of course being as physically active as you can, and having an appropriate diet, having good nutrition. They all seem like pretty basic pedantic things, but these are all related to everything, every disease. So, whether it be cancer or diabetes, cardiovascular disease, every physician in the country will tell you this, no matter what ails you, prevention of disease and essentially trying to minimize the impact of disease is all about having as healthy a body as you can. I think that might be the last question.
Well, thank you so much for staying to answer all of the questions. And again, this webinar will be recorded, so you will be able to see them. But clearly, this is a very important topic, given the number of questions. So thank you so much again for staying and for all of the knowledge you shared with us.
Thank you very much for having me.